I can't fish and I can't change my own slides, so can somebody help me to get to the next place, please? Has it? Not for the first time, the French have come to my rescue. My wife is very sorry, she's entertaining grandchildren at the moment, but she sends her regards to all of you who know her. I wish you could see that photograph, she wouldn't recognise me, I'm afraid. Anyhow, thank you very much for inviting me. Stuart has talked about the first two items on this slide. I just want to say that when it all sort of started, at least for me in 1970, 71, I remember sitting with Martin Barrett, who many of you know and miss like I do, and saying, how can we actually be a specialist in an organ whose function we don't know how to measure? Because most renal function tests depended and do depend on timed urine samples, and that's not an option open to paediatric nephrologists under most circumstances. And it was Martin and others, mainly Martin, and in London and George Schwartz and George Haycock, independently in New York, who began to look at the relationship between creatinine and body mass that led to at least the means of looking at renal function without timed urine collections, and other techniques were developed. I mention that because that also became important in the work of trying to understand growth and metabolism in children. And that's what I'm mainly going to talk about. I'm not going to talk much about psychosocial issues, because Alan's going to talk about that later, or the provision of services and learning. I might tell you a little story there, which you might find interesting if we have time. So this is Heidelberg, this is 1970, and that was my first connection with the European Society of Paediatric Nephrology. There are a lot of things that happened then. I met my good friends the Leumans, who are here, and over breakfast in a hotel, I said to Ernst, you've worked for a Dr. Holliday. Yes, he said. I said, right, will you mention me to him? And I also said to Stuart, do you mind mentioning me to Dr. Holliday? And he said, well, of course. And so various people went to meet Dr. Holliday, other than me, until we were on a boat in the Neckar, when I went to say, and he said, I wondered when you would appear. And I said, can I have a job? And he said, yes, if you find your own money. So the British Medical Research Council stepped in, and off I went to San Francisco. Max sadly died a few years ago, but this is him in his retirement with his sons, and he was a wonderful man. Around this time, he wrote a paper showing that most children with chronic renal failure are anorexic, and they were short of energy in their diet, and if you gave them extra food, they grew. Now, this doesn't come as a surprise to paediatricians, and I remember showing this slide at the International Paediatric Nephrology Association in Washington, and for years afterwards, that's the only thing the audience could remember of what I'd actually said. But this is Tigger from A.A. Milne, and what shall we do about poor little Tigger? If he never eats nothing, he'll never get bigger. So Mac gave them calorie supplements, and they grew. Of course, what we didn't understand at that time was that anorexia was what was keeping them alive, because the big problem of chronic renal failure is the body composition changes that take place in order to keep you alive, but actually stop you growing. And Mac worked all this out and published a wonderful paper in paediatrics around that time. He was actually a professor of fluid electrolyte and metabolism, not of nephrology. And he trained with Gamble, and he pointed out that energy requirement is proportional to metabolic rate, and that's largely determined in children, particularly young children, by the metabolic activity of the brain and viscera, and they form a greater proportion of body weight in children than they do in adults. Thus, energy requirement in relation to weight is higher in the child than it is in the adult. And the kidney is actually an organ of nutrition. We eat according to our appetite, which is determined by our needs for energy, and all nutrients other than energy are consumed in excess of needs, and this excess is excreted in the urine. Now, this was a lot of work over a long period of time, but it is easily summarized. GFR, as you know, is proportional to metabolic rate, which is a proportion to body surface area, and this takes you back to the Martin Barrett and Haycock-Schwartz formula. GFR is higher in relation to weight in a child, and this enables the excess of nutrient intake in relation to weight to be excreted without a change in body composition. Now that's true throughout childhood, except in infants and newborn babies who have very low GFRs. The problem would be, if you took a normal diet, that they would in fact have body composition changes similar to chronic renal failure. But evolution being what it is, the human milk contains an awful lot of energy and not much of anything else. And therefore, you maintain normal body composition as your kidney function increases. So that was a very important contribution, but so was, I remember reading Robert Pitts's book on the physiology of the kidney and body fluids. And for years I used to talk to students about this, that if you consider two people, normal people, adults, each taking a normal diet, which is described here, and one of them's in renal failure and the other has normal renal function, how does the urine differ in quantity and quality between these two individuals? And of course the answer is it doesn't differ at all, because what goes in has to come out. And the difference between the two individuals is the changes in body composition that have taken place in order for them to survive. So anorexia in chronic renal failure is a means of survival looked at in these sort of terms. And so that led us and others to realize that we had to deal with what was then called the trade-off hypothesis. Well, it's easy with protein, just reduce the amount of protein intake, because all nutrients other than energy are consumed to excess. The problem, though, was hyperparathyroidism, because the trade-off for phosphorate retention was secondary hyperparathyroidism. And the consequence of that was renal bone disease, and that leads to all sorts of other consequences in relation to growth and actually other things as well, including glucose metabolism. So what we did was to reduce the intake of these nutrients, including dairy products, and we fed supplements of either aluminium hydroxide, which turned out to be toxic, and calcium carbonate, which turned out not to be toxic. And we also gave energy supplements, because one clever way of getting children to eat a balanced diet was, if you say to a child, look, if you eat that, you're going to die, the child will say, well, I don't mind, I'll eat it. But if you say, do you mind eating this nice sweet drink before you have your lunch, they'll say, oh, that tastes all right. So they drank the energy supplements. Then you could rely on their appetite being suppressed, so they wouldn't eat too much protein and other things. So we were able to show that by controlling phosphate retention, we were able to suppress hyperparathyroidism, and the plasma phosphate levels fell, and they grew. But as I grow older, I find I get very cross about things that didn't used to irritate me. One of the things that always annoys me now is when somebody says, oh, it's only academic. What do you mean it's only academic? I mean, if it's academic, you're learning something. Isn't that important? And another thing is people say, well, anecdotally. Well, you know, the whole of what we know in life isn't determined by double-blind randomized controlled trials. An anecdote is a case report. This is an individual, and individuals matter, just as populations matter. And this girl, she's still alive, has had a kidney transplant, had a very large brown tumour of the mandible. And she'd been to the dentist, and the dentist phoned me up and said, she's going to fracture her mandible. And so I said to her family, I'm afraid she'll need to have her parathyroid glands removed. And they said, no, we don't want you to do that. And so we agreed to put her on this new diet and X-ray her again a fortnight later, then a month later, 6 months later, and it healed, and she never had her parathyroid glands removed. This is another anecdote. The man in the middle with the dark glasses, 3 from your left, owns a water sport service in Limassol. And he had at this time a plasma creatinine of 1,000. And he has a normal hemoglobin, around 13 grams. He had normal blood urea. He had no sign of any bone disease whatsoever. He was in chronic renal failure and was for many years. He was originally a patient of Martin's at Great Ormond Street, and then we were involved later. And the reason he's like that is because he'd worked out for himself that he should not eat much in the way of dairy products. He ate a lot of pasta, a limited amount of protein, but he was in the sunshine all day. And so he didn't have any bone disease. He did really very well until he went off to do winter sports in Africa one winter. I said, don't do that. If you fall ill, you'll be in deep trouble. And then one day I got a phone call from Heathrow Airport saying, I won't tell you his name, he says, it's me, I'm not very well. So I said, get in a taxi, because he's an adult by then. He came to Guy's. I got Dr. Oz Chisholm, Stuart's colleague, down to the casualty department. We admit him in, his potassium was 8. Anyhow, we resuscitated, and he went back to Cyprus and has had a kidney transplant. So growth and nutrition in children with kidney disease was a very important part of our work and your work in the early days, because we were not alone in this. There were lots of other units working in this area. And the conferences certainly was going on until the last one I went to, which was in 2012 in San Diego, but I'm not sure, Elena, whether they're still going on now. But so that was chronic renal failure. Now, what about dialysis? Well, the same problems arise in dialysis. You've got a small child with a large surface area, a large metabolic need, and the relationship between weight and surface area, between circulatory volume and surface area, is different to adults. So that means that for a small child on dialysis, you need to be careful about what they're eating, you need to make sure they get enough energy, but you also have a problem between the size of the dialyzer and the lines and the need for dialysis. So we had to work out, I never knew how to dialyze a child, by the way. I was regarded as an expert in dialyzing children. I could work out this stuff about the amount of dialysis and the size of the lines and that sort of thing. But if anybody asked me about how to dialyze a child, I said, well, go and talk to Miss Winder. Miss Winder was the nurse in charge of the dialysis unit. She knew how to dialyze the children. I didn't know how to do it, and people thought that was very strange, but that is the truth of the matter. I did know how to work out the size of the dialyzer and the need for dialysis, so that had to be worked out. And again, I'm sorry about this slide, but when I was asked to do this talk, I hadn't actually spoken about nephrology since I retired at the end of 2000. And so I had to go to the attic, and I found all my old slides in a carousel. And I went out and bought from a place called Maplin's a way of copying them. This is the result of one of them. But what it shows is that we had children were growing on dialysis. The size of the dialysis machinery did seem to dwarf the children on occasions. Alan Watson will tell you how important it is for education and schooling to go on. And this is a child on dialysis, and that's the school teacher doing his homework. Transplantation. Again, a problem. You've got a small child. It has a low blood volume, which is related to body weight. You're putting into this small child a large kidney, because the kidneys often came from small adults. It has a large blood volume with a high perfusion requirement. You need to maintain a high urine output immediately after transplantation, and the margin for error between going to shock and circulatory overload is small. Now, this is in the mid-1970s. Well, when I qualified as a doctor in 1963, the treatment of shock was to put up a noradrenaline drip. And one of the jobs of medical students was to sit at the side of the bed, dripping in the noradrenaline and measuring the blood pressure for somebody in shock. I never saw a patient survive a noradrenaline drip, And I don't think any of my fellow students had ever had that experience. But that's how it was treated. Even in 1963, when I took my qualifying exams, I'd said, well, actually, the treatment of shock is to give intravenous chlorpromazine and cause venous dilation, drop the blood pressure even further, and pour in salt and water. They'd said, well, you can come back next year and try again. I would not have qualified. But a man in 1967 said that is the treatment of shock. And this was, to me, a very important paper. And so what we did was we tried it out on children having atrial septal defect repairs and also children having tonsillectomies. And we showed that if you gave volume replacement, you could suppress the volume and control of antidiuretic hormone, and you suppress the vasoconstriction, and the feet were warm. So you could feel the temperature of the feet as a means of ensuring you had an adequate circulation. So the treatment is open up, fill up, and stop when the feet get warm. And actually, a cardiac surgeon at Guy's, who still remember Sir Russell Brock at that time, was doing quite extraordinary open heart operations. And he would come round the ward in the evening before he went home, and everybody would be telling him all that was going on, but he wouldn't be listening at all. He'd just go and feel the feet. And if the feet were warm, he'd go home. And this slide shows children having an ASD repair, showing that if you do supplement them, this time with plasma, you can close the temperature gap, you suppress the antidiuretic hormone, and you perfuse the kidneys. Now, this worst slide also comes from the attic, and it was drawn by my 10-year-old son. And he's now a consultative intensivist in a hospital in the middle of England. But he drew this because he was very keen on his draftsmanship. And what it actually shows is that a little boy, 13 months, having had a kidney transplant, you'll see that to begin with, there's a wide temperature gap. It then closes as we pour in the fluid. The blood pressure is stabilized. Up comes the venous pressure, up comes the urine output. So it's an example of opening up, filling up, and stop when the feet go wrong. So we gave intravenous chlorpromazine and poured in the saline. There he is. And those were the early results of the first cadaver graft survivals. Alan's going to talk to you about the multidisciplinary team, and I'm just going to end by just saying a few words about provision of services and learning. And I'm going to tell you a story because I find it quite funny. But it's a very sort of UK thing. But one of the things I learned from Mac Holliday was the need to try and organise services in a way which actually gives the best chance of success for our patients. And Mac wanted to persuade the United States Senate, and he went to Washington a lot when I worked for him, to establish a number of centres around America where they bring together all the sort of services Alan's going to talk about into one place to ensure that you had what you needed, the relationship with adult nephrology, paediatric nephrology, surgery, and all the rest of it. Matt failed because they didn't want to do that. But when I got back in 1972, I spoke to Ian Houston in Manchester and Dick White and to Martin, and we produced this document, Future Care for Children in Chronic Renal Failure. And it was, and we'd gone around the country, we'd seen where the centres might be, where the paediatricians were interested, where the adult nephrologists and all the rest of it. And there were 12 centres. So we sent that off to our Department of Health, and they said, thank you very much, and nothing happened. So in 1980, we produced another report. Martin was on the second one. And we sent that off to the Department of Health, and nothing happened. And then in 1983, Mrs. Thatcher, who was then the Prime Minister, was interviewed on the television, and she was attacked about the lack of services for adults needing bone marrow transplants. And the interviewer said, Prime Minister, why don't you establish national centres? She said, well, it's funny you should ask that. That's exactly what we intend to do. Well, that was news to the Department of Health. But the next day, they were told that's what they were meant to do. And there was our report. And so they phoned up and said, we're thinking of establishing centres across the United Kingdom for children with renal failure. So, these things happen in strange ways. We were always very, very determined to share our results. One of the strengths of the European Society of Paediatric Nephrology, and of nephrology generally, was you share your results, you learn from each other. I mean, I was always talking to Michelle and going to meetings and talking, learning all the time from each other and publishing the results. We don't need politicians to tell us to publish our results. We want to know them ourselves, and we want to learn from them, we want to share them. And we've been good at that, and that continues. And this is the report which somebody's mentioned, Joachim mentioned earlier. I gave the paper on the 25th anniversary of the ESPN, it was the 24th meeting in Rome, and I wrote about paediatric nephrology on the threshold of European integration. So it's good you've invited me back today, and I'm sorry. But I hope that we won't lose that, at least for our country. But we did have quite a lot of fun as time went by, and this is me having fun, and that's Stuart having fun. Thank you.